Good morning, everybody. It's been clearly introduced a number of concepts that it's the base of this project, that is big project we are being involved during this year. And the idea of this presentation is to give some more data regarding what forced this group of physicians to do this job and what is the background from which we start. These are my conflict. Obviously, I cooperate as a part of the clinical committee on this project. It has been already said that almost half of the in-hospital cardiac arrest happen outside the intensive care. This is the big study, has been already cited before. It's about a huge number of patients, and we can see that almost 40% dead outside the intensive care. But what is much more interesting is that the point, yes, that the respiratory cause is much more present in patients that are outside the intensive care. So the reason for that is respiratory in a huge amount of cases in the outside the intensive care patient. Is there a problem of oxygenation in the ward, and especially in the postoperative phase? This is a very interesting study that has been cited a lot of time, that studied the period, the immediate postoperative period of a huge number of non-cardiac patients to see what happens in the first 48 hours. And I'm not describing all the curve, but we have that around 21% of these patients have at least 10 minutes per hour of saturation lower than 90% in a non-selected population of non-cardiac patients. And we have 8% that have at least 20 minutes per hour with a saturation lower than 90%. I don't think we are so happy to have our postoperative patient having this amount of the saturation in the postoperative phase. But in the same group of patients, 37% had at least one episode of desaturation lasting longer than 1 hour, not only an episode, something that sounds to be a problem. But we know that we use standard monitoring usually. There are nurses, there are records. But in these cases, we bet that the saturation was being reported in the flow sheet in less than 5% of the cases. So the great majority of these cases has been detected by blind monitoring, not by nurse or physician. But even if you look at the patient that have no experience of hypoxia reported, we have a huge number of patients having the saturation lasting 1 hour or even 2 hours. And we know, and it's been proven, that due to the characteristic of this episode, it's very difficult for the nurse to get this episode. That usually does not hesitate in a major problem, but they characterize the postoperative phase. Who is this patient who suffered this kind of desaturation? This is another study already cited, looking at the closed claim, and that is something that is very precise usually, in the period in the last 20 years. And we have that the patient who has respiratory depression is typically obese, could be. We are a little bit worried about obese in the postoperative phase. But strange is patient that is usually has a status lower, so the patient we believe are in a better condition. No, without the diagnosis of OSA. is patient that has a multimodal postoperative therapy. And it's very uncommon that the problem of respiratory depression is related to an excessive opioid use. So it's usually patients that we would not believe are at major risk of respiratory depression. It could be also logical. Let's say the patient we expect not having a problem is less monitored, less perhaps followed, and there's the patient who develop more frequent the saturation lasting also longer period. This has been shown again is the same study, just to give an idea. Among this respiratory depression event has been checked the discovery of the respiratory depression is in the range of 2 hours from the moment in which nurse check this condition. So it passed a long period of time in between the check and the development of respiratory depression. And the outcome is very bad. We know that half of this patient is going to die. It has been also shown that opioids and sedatives that are typical for the postoperative phase are factors that deeply related to the development of respiratory depression, cardiopulmonary arrest. We have that having opioid and sedatives increase by 3 times the risk of having a kind of problem like this. And as expected, the length of hospital stay has been longer, the length in the intensive care is longer, and the cost is usually very much higher in the case in which the patient developed some kind of problem. So it's frequent, it's quite common, and it is a heavy impact on the postoperative phase. What can we do to reduce this? Certainly, it's easy to understand that preventing intraoperative cardiac arrest is something we want to obtain, and in time perhaps we are able to reduce the mortality in our department, intensive care, and in the ward. But the real problem is to identify the patient at risk and monitor them correctly, just to avoid this kind of phenomenon. And there are a number of experiences trying to identify this patient. First of all, we know we are all afraid of patients with obstructive sleep apnea that are a major risk of depression. And there's been studied that the stop-bang questionnaire that has been used to identify patients with obstructive sleep apnea is perfectly able to identify this patient. But unfortunately, is not able to predict postoperative hypoxemia. If you test this, you are able to identify this patient, but not the patient at risk of postoperative hypoxia. Another opinion or consideration that the use of different kinds of opioids could play a role in the development of respiratory depression. And actually, there is no difference if you use long or short-acting opioids in the number of hypoxia phenomena we get in the postoperative phase. So it's not really so easy to identify the patient at risk. Another factor that we usually use and has been studied, that we know that patients in the postoperative phase for safety are treated with oxygen, some kind of oxygen. And that's been demonstrated in volunteers that using oxygen play in some sense in contrary as expected. The respiratory depression is more pronounced during hypoxia, either on minute ventilation, either on respiratory rate, and obviously having oxygen, the effect we see on monitoring pulse oximeter is very delayed. Obviously, we have oxygen, pulse oximeter remain at a higher level. And so in some sense, what we use to prevent hypoxia is something that acting against the development of respiratory depression. Monitoring has been proved to be efficient. If you compare the use, simple use of pulse oximeter in respect to clinical, there is a reduction of the transfer to ICU. But the use of both capnography and pulse oximeter is able to reduce the respiratory depression event for an amount of 6 times. So, especially in the case in which patients are treated with oxygen, the use of capnography is able to identify and help finding the patient at risk. So this is the idea that was at the back of having this study, exactly designed to test this. Are we able to detect in postoperative patients treated with opioids respiratory depression, and perhaps to identify the characteristic of the patient and major risk of this phenomenon just to prevent this event? It's clear, I have to say this, that we are not talking necessarily of clinically representative events. We are not in the position to say that this will prevent death. At the moment, the point is to identify a system to prevent depression. Even if we are not correlate depression to death directly, I don't think no one in this room would be happy to have a postoperative patient with respiratory depression. Also, if this will not play a major role in this outcome. But I think everybody prefers not to have respiratory depression at all. So, as I said, the objective is to try to define a score to identify the patient at risk. And let me say, also to measure the dimension of the phenomenon in a big multi-center study. And this is extremely interesting. The idea is to collect some blind data from the machine, we will see later, and to collect some clinical data regarding what's happened, which kind of drugs, which kind of monitoring, which kind of treatment they had, and to put together this story under the evaluation of a group of physicians, just to put together what we get and give an interpretation on this. Which are the patients included? All patients treated with parenteral opioids in the ward as a postoperative treatment, adult age, and simply, let's say, normal postoperative patient, unselected, expected to stay at least 48 hours with no major problem, no ventilation, no participation in other study. Let's say we can describe as normal postoperative patients staying in opioid therapy for at least 48 hours. The objective, I said, is first of all, derivate and validate an assessment tool to identify this patient. We will see later. But obviously, having collected so much data, the idea also to describe, if we can, which patient developed respiratory depression, which not, which are the characteristics of this population. And if we can try to describe the path the patient have before and after this event, to describe the evolution of the depression, the respiratory rate, the capnography, and so on, to understand the path, if there is some typical path, and perhaps to have an idea of cost. Let's say, if you look about the idea of implementing new monitoring system, there is always something in the hospital that asks you how much does it cost. It costs benefit of the treatment. So we have to evaluate also this. As I said, we collect data into different systems. One comes directly from the machine and is registered in the machine itself. It is the CO2 and tidal, respiratory rate, SpO2 and pulse rate. And then we collect by electronic form the data of the patient, mainly, as I said, as is shown here, regarding the use of opioids, other drugs with sedative properties, other treatment regarding pain, the use of drugs to reverse opioids in the case of needs, and in some sense the course of the treatment and drug during the 30 hours of study. As I said, the first objective is the respiratory depression. Respiratory depression that could be collected or automatically by the machine. Let's say it's been designed an algorithm to identify in a continuous monitoring system some episode that can be associated with a depression. That is an end-tidal CO2 lower than 15 or higher than 60 for at least 3 minutes, or hypoxia lower than 85 for 3 minutes, or the reduction of respiratory rate or apnea, or other factor that the clinician identify as related to depression. Obviously, the machine is able to collect data, and then we have to compare the clinical data with the data we collect as a story, just to collect what can be a wrong event, let's say the monitoring system that is not in the correct position or movement of the patient, something like this, to identify the real event. And this is the role of the clinical event committee, just to put together the data that comes from the machine and the data that comes from the story. Obviously, the event, as I said, can be described in the sheet, can be described in the data coming from the machine, but all this data should be put together just to identify the real setting. Which is the reason? We know that in 48 hours, especially for capnoGraphY monitoring, could be that the patient moves, could be that the cannula is not in the right position, but usually if we have, like, as an example, no capnographic data and for a long period of time and no intervention, it sounds there is something that is related to the machine, to the monitoring system. It's uncommon to have a patient not breathing and nothing happen. So just to identify which among the event identified by the algorithm was really event or was a bad signal. In my experience, this is extremely important because I don't know if who of you have major experience in the use of capnography, but in my own experience, it's completely different approach in the nurse, especially in the operative room, regarding the alarm of pulse oximeter and the alarm of capnography. When the pulse oximeter start alarming, everyone run because there is a problem. They start considering pulse oximeter a solid alarm system, and in the case of alarm, everyone is worried about to check. The first opinion when there is an alarm in capnography is bad reading, because the great majority of people that are not used to use capnography believe that the event you show in the monitor is related to bad monitoring and not a problem of breath. So it's completely, our approach to the two machines is in some sense different. We, great majority, do not trust that an apnea period is related to a real apnea period, but is much more the cannula that is not in the right position. The idea of the clinical committee was exactly to put together the data that comes from the blind monitoring with the story of the patient. This is the name of that be involved in this project, and I show us some data just to understand what we have to look. This is the data that comes from the machine, obviously in 48 hours, so we had huge amount of number. But as you can see, you have collected the CO2 during time. This is the CO2. We have the SpO2 and the pulse rate and the change during the day. Obviously, the software, the algorithm that has been designed, was designed to identify automatically the situation in which some of the criteria I showed you before was present. And in the case, they put a line on this to show in this moment one of the limits of the respiratory pressure criteria has been reached. And in that moment, this was the story of the patient. He's doing that drugs, he have this monitoring, this happen, and so on. So, do you believe that this event is a real event related to the story, or can be attributed to a technical or other problem? Could be due to level of CO2, level of respiratory rate, level of SpO2. Obviously, what do you expect is that there is a relationship between respiratory depression, perhaps increased heart rate, perhaps desaturation, and perhaps intervention of someone. Or, like in this case, there is in the story of the patient that at that moment there has been an intervention to treat an opioid administration, like in the case of a drug administered for a clinical problem. So the point here was to put together all this information and to understand how often this phenomenon was true, even without a clinical outcome. We are not looking at patients that got bad or going well. But especially is not now the moment to show all the curve because a huge amount. But the number of events in which, perhaps I can able to return back, in which you have this kind of phenomenon, especially, you see now, here's 1 a.m., especially during the night, especially in patients treated with oxygen, with an alternative path, normal breath, respiratory pressure, short apnea, then big breath. It's extremely frequent when, if you look at the medical sheet, nothing happened in all that period of time to change therapy, to treat this. Simply the patient, let me see, starts sleeping, and they start sleeping, having period of apnea, having period of shallow breathing, in some cases with an impact on saturation, in some cases without an impact on saturation, but certainly is something that I personally would not like to see in my patient after surgery. Just to be the maximum precise, the job was done at least by 3 reviewers independently, and it was decided that an event was considered a real event in the case that 2 out of 3 independent reviewers agree about this interpretation. In the case in which there are disagreement, there was first a discussion, electronic discussion, then a telephone call just to discuss together the analysis, and in any case we maintain a log of all the cases in which there was a discussion regarding the interpretation of some path, because in some cases the path is not so easy to interpret. And we are sure that the results are solid in respect to interpretation of what we see. This is the story. We have not shown any results because there are others that are in charge of this. I hope to have clearly exposed the problem and to take you on an important arena. The great majority of you treat operative patients, have opioid in the postoperative phase. but the great majority of these patients are not so solidly breathing as we expect. Thank you.